So I've come up with my own acronym for talking with patients and families when there are a lot of big emotions and it's difficult to come to an agreement about the plan. And the acronym, I think about it like a checklist. Like in surgery, you need to have the first step met before you go to the next step. So if you check the person's name and birthday and it doesn't match, you're not going to go on to step 2 or 3. So the same thing is true for my acronym. And so the acronym is called NAMES. And I like that because I'm terrible at remembering all the things acronyms stand for. And the first letter, N, stands for name the feeling. So even if you forget everything else, that's the most important one. So whenever you feel like the air is charged, the patients or family are upset or confused or frustrated, anything, rather than moving forward with any explanation, try to name the feeling. So you must feel really sad. You must be angry. I understand you're feeling frustrated. And it is okay if you get it wrong because they can correct you. It's a way of opening up dialogue to show that you care about what they're feeling. Unless you've named it, they won't believe you because they are in a completely different place than you are. They are in the hospital bed. You are standing above them. And so by naming it, again, you are sort of extending a bridge to show that you care about what they're feeling rather than just saying that you understand or you know what is going on. You need them to say, yeah, that's right. I am tired. I am frustrated. And you will feel the tension decreasing in the room. And then A stands for ask. So it's only then that you can start a dialogue. But the dialogue shouldn't start with explaining, educating, telling them anything. You need to start with figuring out where they are at. So asking what their understanding of their illness, the course, what brought them to the hospital. They might have a completely different idea compared to what your understanding is. And so they can't understand the plan that you will propose unless you match it to where their understanding is. One example is that I had a patient who on all of the notes was written as non-compliant with diabetic diet. He was Spanish speaking only. I had an interpreter and asked him what his understanding of diabetes was. And he said, well, my family had it, my mom had it, my grandma had it, and if you go to the hospital, your leg gets chopped off. That was his understanding. Obviously, describing the treatment plan to him would be very different compared to somebody who just said, I know I'm eating too much sugar, but I love it and I can't stop. And similarly, you really want to understand what they want out of their hospital experience. Do they want to get out as fast as possible, or do they want to understand what's happening and have all the diagnostics done? And it's helpful to know what their goals are so you can address whether or how it can happen. Then M stands for match or mirror. You want to work on understanding how they got there. If I thought that every time I went to the hospital I had a risk of amputation, I would want to leave the hospital too. Or it sounds like it's really important for you to X, Y, and Z. And again, this helps address what I talked about before, in that every person is a 3-year-old deep inside. But when you're in pain, sick, hungry, poked all the time, that 3-year-old is more apparent, and having their feelings validated is even more important. And so by you summarizing, rephrasing what they're saying to show that you fully understand how they're feeling and what their goals are, that again will decrease the tension in the room so that they are ready to hear what you have to say. And that's when you get to the E of educate or explain. Too often, medical professionals sort of just waltz in and start with that, but the patients and family aren't ready yet. And that can lead to a lot of the miscommunication and distrust between medicine and patients that we see today. So by tailoring your your education, to what you've learned before about what their goals are, what their understanding of the illness is, tailor not just the content, but also the method of explaining it, getting it to whatever education level they are at, making sure the language is appropriate. If they are visual, drawing out or bringing up pictures on a phone or an iPad can be helpful. All of that so that they can actually now meet you where you are to understand where you're coming from and explaining the diagnosis and the treatment plan. And you don't have to necessarily do all of them in one session. Sometimes you might be so surprised by what their actual goals are or their understanding. You might need to say, okay, let me come back and get more resources so that we can get on the same page of understanding. But once you get to that process, once they can express and summarize what you're trying to talk about, that is when you can work together on a treatment plan. So the S stands for strategize. A lot of times the plan is given as a absolute. And again, if you are a 3-year-old deep inside, you want to have some choice in the matter. Nobody likes to feel pressured. And this is true for all adults, but again, it's even more important to somebody when they already feel like so much of their control is taken away from them, such as what they can eat, when they can sleep, when they can wake up. And so the more they can feel in control of what happens to them, the more the plan will work smoothly. So you can, again, take the treatment plan, but then provide options that can be tailored to what they said before about their goals and understanding, and you will find that you'll get much better treatment adherence, much better rapport if you do it this way. And this sounds like a lot, and what I like to tell my medical students is slow is fast and fast is slow. The more urgent and important the decision, the more slowly and carefully you need to be explaining it. And because if they're really sick, if there's big decisions, they're not going to be able to process it well. And the more you apply pressure, the more complicated jargon you have, the more they want to take a step back, pause, and sometimes take time that you don't feel like they have. So taking just a few extra minutes of making sure they understand what's happening, they feel like you understand what they want out of their treatment, the more they'll trust you and both tell you their hesitations so that you can address them, rather than just saying, no, I need to think about it, and you're left in the dark. But then you will be able to move forward much more smoothly and also avoid any difficulties or questions later on. And the patients themselves can this way avoid a lot of medical trauma that can happen when it feels like choices about their care are taken away from them. In 4th year, we had a standardized patient where we'd all go into private Zoom rooms with standardized patients, and our task was to counsel them on getting a central line. And I used my acronym names, even though supposedly this patient has sepsis and needed a central line. I just started out with asking what their understanding of what brought them into the hospital, what were their goals, and then tailored the recommendation of the central line at me taking the time to ask them questions and explaining very simply and carefully what their condition was and why we were recommending this invasive procedure. I ended up being the fastest to get out of the Zoom room. And you'll find that the better you get at doing this, the more efficient you'll be, and the patients will get better care. And let me know if you have any questions in the comments, and I'll keep on giving you tips for preparing for intern year.